virtual reality and immersive technologies lab.
Interesting, great. Dr. Bajestan, can you tell us a little bit about yourself?
Of course. So I'm also a neuropsychiatrist, and I used to be a neuroscientist. I worked a lot in molecular and cellular biology of a lot of psychiatric and neurological disorders. And I did my training for psychiatry, neuropsychiatry at Stanford, and I'm involved in teaching, research, and clinical work in neuropsychiatry. I'm the main one of the two consultants with Department of Neurology, especially epilepsy monitoring unit for the neuropsychiatry consults. And I'm the associate director of the neuropsychiatry and behavioral neurology fellowship here at the Stanford University.
Great, we're so happy to have you both with us. It's such an honor, and it's so helpful to patients to realize that there are a lot of doctors out there that are trying to help patients, and that's kind of what we're really trying to promote with these webinars. One of the questions that we've had that have come in, I think we'll kind of we'll start with you, Sepideh, is about non-epileptic seizures. Maybe just if you could give us a quick brief, what is the difference between an epileptic and non-epileptic seizure?
So there is a difference in terms of what happens mechanistic way. So in epileptic seizures, we have changes in the EEG. So we have malfiring of brain neurons, and that would induce an epileptic seizure. For non-epileptic seizures, we don't have that EEG changes in the brain, but we have seizures outside. We have the movements that we can see outside. So that's from the definition and mechanistic difference between the two. And if we just look from outside, the type of movements in epileptic seizures and non-epileptic seizures could be different also. So to some extent, not completely, they could be distinguished from the type of movements as well. So this is just like from mechanistic way of looking at it, and from the outside seeing the symptoms.
How is treatment different?
So usually for epileptic seizures, patients need to be on medications. On anti-epileptic medications, we have different medications from Depakote to Keppra to phenytoin, different types of medications to get the seizures under control, pretty much get the EEG back to normal. And sometimes they have to go through more invasive treatments like surgeries to have it under control, and it's more of treatment. For non-epileptic seizures, first of all, they need to make sure that there is no epileptic seizures involved, because around 15 to 20% of patients who have epileptic seizures may have non-epileptic seizures also. So if that is teased out for non-epileptic seizures, then they should have a very good neuropsychiatric assessment, figure out if they have any comorbid psychiatric disorders such as depression, anxiety. Those needs to be treated. For psychogenic seizures themselves, usually psychotherapy, different modalities of psychotherapy is the mainstream of treatment, and also hypnosis could be used for treatment also.
Great, thank you. And just so for some of our viewers that are on the webinar, a reminder, if you haven't been to a webinar before, if you'd like to ask a question, you can put it in the Q&A and I will ask the question for you. And if you would like to ask the question yourself, you're welcome to raise your hand. There's an icon on your screen and we will bring you over as a participant, and you will not be seen, and it will only be your voice, and you can ask either one of the panelists a question. So please feel free however you feel most comfortable. We're starting to get a couple questions in. So I'm gonna go, I think this question would be good, maybe if we have Kim come on and answer, is what happens if you've tried everything a psychiatrist or therapist has suggested and you're using all the techniques, but this is not working? What else do you suggest?
Oh, that's a really good question. First, we're assuming that, a thorough workup has been done and everything has been ruled out medically, and that one has actually really tried all the techniques that are out there. And let's say that is the case. We think of this as a multifactorial disorder, much like migraines. People can be vulnerable, have certain vulnerabilities, maybe genetic, biological vulnerabilities, that there's triggers, there's things in the environment, and much like migraines, often the treatment has to be kind of lifestyle. But that being said, sometimes those variables are just too powerful and they can't be changed, or maybe they can be changed, but at another point in life. So the type of therapy, one of the types of therapy that I deliver is dialectical behavior therapy, which is a combination of change-oriented and acceptance-oriented therapy. So I'd say if you've, gone along and tried to change what's going on, and you can't change it, then what you've got to do is learn acceptance. And so I'd say, that really working on acceptance strategies, because sometimes what can cause, there's normal pain, but when you're trying to change and you can't change something and you're trying to force it, you can add another layer of suffering. Whereas if you can come to some acceptance about things, sometimes that can lower the suffering level a bit. So I would say if you tried everything and you're sure you've tried everything, if you check the facts, then the thing to really work on is acceptance. Like many people with medical diseases and disorders, a lot of the strategies involve coping and acceptance.
Thank you. That's a really good point that I think that you bring us to, because I think that sometimes you have tried everything within your realm of whatever's available to you. There's also obviously a lot of things out there, but they're not always all available to everyone. So I think that that's really important. We have a question from one of our members, and so I will go ahead and keep on the camera on you, Kim, but we may need to switch over. I will go ahead.
Hi, my name is Angela. My daughter, my daughter's 19. She started with non-epileptic seizures at the age of 16. No traumatic onset of any of this. She's been through several years of counseling. They haven't found anything that could have triggered this to occur. Her non-epileptic seizures are mobile and often violent. She hallucinates during them. What, if anything else, could we do other than, we've done therapies, we've done, I've gone down the list. She has almost every symptom listed on the FND website she has experienced. All the psychological things seem to hit her stronger. Her world has come down to 2 friends and many days inside the home because almost everything triggers. What other options are possible?
I'm sorry, who did you want me to go first?
I can say whichever one you feel most comfortable.
Sure. Wow. Yeah, I'm sorry to hear that. That's a really challenging situation. Well, first of all, again, I would say make sure that you've had a thorough workup, at least, to neurologist. Yeah, there's some unusual factors you're talking about. There's no triggers. In the history, there's no vulnerabilities. It sounds like often people have had some kind of somatic trauma of some sort that's happened to their body that hasn't happened. The treatment isn't working. So I also would just make sure that, you know, all the medical causes have been ruled out. You know, hallucinations is a bit unusual. It does happen, but it's an unusual presentation. And so, so you're asking what else could be done? Is that?
Yeah.
Yeah, so I think if you've got to also think about like what types of treatment have been done. So often triggers, there's a desensitization to triggers that needs to be done instead of avoiding triggers. Has that been, have you gone down that path where she's actually exposing herself to triggers and desensitizing to them?
We've tried, but everything seems to trigger still. I mean, anything from looking at a sharp object to watching a bank robbery on television that's fake can trigger her.
Yeah,
So
often
her world is very narrowed now, and her maturity level has even dropped accordingly. She focuses more on cartoons because that's the only thing that doesn't trigger.
Yeah, yeah. Well, often you've got to find the right dosage of the trigger to desensitize to, often like allergies. You know, if you give too much of an allergy shot, the person's going to get allergic and sensitized rather than desensitizing. So I would also encourage you, you know, from a CBT point of view, and if you're going to go down that route of behavioral desensitization, you've got to find the right dose. So sometimes people get discouraged, but really it's a dosage issue where you're not getting the small enough level of the trigger to desensitize. But I'll let Sepideh also, Dr. Bajestan, weigh in on this, because there's multiple different ways that different therapists and providers will approach this, but that would be one of my first thoughts, just hearing your case.
I'm so sorry to hear that it has not been an easy road for you and for your daughter, and it's very, very challenging. And you deeply care for her. You're here to figure out what else you can do. I would echo what Dr. Bullock had said, and Dr. Bullock had been my mentor for many, many years. So I would totally echo what she just said. I am hearing as is kind of a sequel of the non-epileptic seizure that your daughter has been dealing with is some social isolation also. So I would suggest, in addition to everything that you're doing, perhaps some group therapy could be helpful also. If there are group therapies in your area for patients with non-epileptic seizures or somatoform disorders or FND, that could be a safe place for her to start being around people who are suffering also, but at the same time, getting out of that isolation and working on the treatment. Both Dr. Bullock and I, we have group therapy, but these are treatments that last long, at least in our groups. They have to come on weekly basis for a few months. And that usually reduces the isolation and help people to have more understanding of their triggers and what helps them. So I would suggest if there is an availability, that might help as well.
Great, thank you so much.
Oh, I also wanted to say too, you know, adolescent psychiatry is another field too, and they're usually the whole family is taken into the treatment. And so also I'd encourage you, if the family isn't, the whole system isn't being treated, that you could try that as well. Again, I treat only adults, so I'm not as versed in adolescent medicine, and we have a whole different team that takes care of adolescents and young adults. But definitely more emphasis on the family. And so you as a parent can influence behavior quite a bit, so might think about also targeting that, but that may be something you've already done.
So I think one thing that kind of we've talked about a little bit, some of the treatment that is available. We've talked about CBT, DBT, and you mentioned a little bit what are the differences between the two?
CBT and DBT?
Yeah.
Oh, well, DBT is a form of CBT. It's like a third iteration. It's a hybrid or third generation, they call it. So DBT is just a amalgamation and hybrid of more traditional cognitive behavior therapy that's very change oriented, and then it's merged with the more Eastern philosophy of acceptance and change, acceptance strategies, and which come from kind of Buddhist Zen principles. So it's a merging of those. And DBT has a real emphasis on emotion regulation and on that as kind of an overarching model for almost all disorders, that a lot of all of our problems kind of can be managed or helped by regulating emotions. So it has a real focus on emotions and emotion regulation, and the neuroimaging data on FND is really showing that those limbic areas, that amygdala, is the area where there's some problems in the brain. And so I think it also is a bit more neurobiologically based, because it's kind of a more recent development in CBT.
That was one of our next questions, is that we wanted to, if either one of you can kind of explain, is how psychological therapies can actually change the brain in some, does it change how the chemicals, or how does it change because of emotion and things like that?
Well, I'll let Sepideh, Dr. Bajestan, talk more about that. She's the expert in neuroscience. But from a DBT perspective, we've got some great new evidence that's come out that actually 1 year of DBT in one population was shown to desensitize and normalize this area of the brain called the amygdala. And they were able to show that, and it correlated beautifully with this emotion regulation scale. So I think we really know that the areas of the brain that are involved with emotion regulation with psychotherapies, there is a change. So it really is, I think of it as bloodless brain surgery when you're doing psychotherapy.
Great. Sepideh, do you have anything you'd like to add to that?
Sure. So in terms of neuroscience, I would say I hope that we would be at a point that we could see the changes that happen in the brain in all of our patients with, for example, functional MRI. Also, in terms of clinical work, we are not at that point there yet, but with research and having enough number of patients or subjects in research, they have been able to see changes before and after psychotherapy, for example, in patients' brains. It's not a structural changes, it's mostly functional changes. We use the metaphor of hardware and software of a computer, for example. So if you have some difficulty with your computer, it's not always something hardware-wise in it that you can see. It could be the software that you need to have another type of programming for your computer. So if we use the same metaphor here, psychotherapy, not only for FND, for any other psychiatric disorder like panic disorder, PTSD, they have shown that after psychotherapy, we see changes in the way that, in terms of function of neurons, they're talking to each other. And it can be seen by functional MRI, which is not available for clinical work yet. So it's not at the point of seeing changes in one single patient. And as Dr. Bullock had mentioned, what we see in a lot of psychiatric disorders and in FND also is hypersensitivity and hyperactivity of limbic system, like amygdala anterior cingulate gyrus, different parts of limbic system, and hypoactivity of cortical part of brain, usually prefrontal cortex. So with psychotherapy, different types of psychotherapy, the sensitivity in limbic system usually reduces and the executive function of the brain increases. So prefrontal cortex and frontal cortex usually have kind of executive overview of limbic system. And if a person goes to fight or flight response, usually through cortical or PFC, prefrontal cortical part of the brain can override that and reduce that sensitivity. So when this connection is not well wired, we have them just working not in sync with each other. With psychotherapy, we can have them be more in sync and have more of a normal wiring going on rather than just working in different ways and not in sync with each other. And in terms of psychotherapy, I would add there are different modalities of psychotherapy, and research has shown that most of them are helpful. We have CBT, we have DBT, we have hypnosis, we have psychodynamic psychotherapy, and we have research more for one part more than the other part. For example, CBT has been well studied through research, but other forms of psychotherapy could be pretty helpful also. I want to just have this message out that if a person is working with a therapist and they have a very good alliance, they're working well, not to get worked up that if this is not a specific type of psychotherapy. All of them can work. Is the most important part is that the patient and the therapist have a good alliance with each other and know that they can understand each other and work on issues.
Great. So are there other, so you're saying that the CBT, DBT, whatever type of treatment they're getting has potential to reconnect these parts of the brain together so they synchronize and work, right?
Yes, in simple.
Are there other things that can play or kind of wreak havoc on the brain, such as hormones, or you mentioned the fight or flight and cortisol? Are there other hormones that should be checked with this standard?
Of course, like so while we are talking about psychotherapy, we are assuming that other medical and neurological issues have been ruled out. For example, even for a patient with simple depression or anxiety, we are just talking, not talking even about FND, which could be more complicated. We need to make sure that at least hormones have been checked, at least thyroid hormone has been checked. Or if we see symptoms that would make us think that we have difficulties in having a balanced cortisol, that should be checked also. They can play out, we have studies that they show that like if people have hypo or hyperthyroidism or different levels of cortisol, it can affect the limbic system also and increase the sensitivity. So that is for sure needs to be looked at. And it doesn't mean that if a patient had ruled out those issues, they are immune to them for the rest of their life. So if they have some symptoms, clinical symptoms that would go through suspicion for difficulty, imbalances in cortisol pathway or thyroid, that needs to be checked out also.
Okay, great. We have a couple questions, and I think the first one we've kind of already hit on is he'd mentioned his wife had been diagnosed with needs, and how does neuropsychiatry treatment help, which I think you just touched on as far as reconnecting the brain. And then the second part of the question was the benefit and symptom improvement is seen. I think we kind of now touched on that as well. Some don't see improvement necessarily, but they then can find a place of acceptance and moving forward, and some can be cured. Is that not what you've seen? Great. So I think it helps to just kind of recap that there are varying degrees, and it doesn't have anything to do with how hard you're trying, or, you know, and I think sometimes there's this feeling of, I'm not trying hard enough, or maybe our family member's not trying hard enough. And I think it's so important that we make sure that we clarify very clearly that how someone responds to treatment doesn't necessarily have any correlation with how hard they're trying or not trying. Sometimes it's just not connecting. Another question that we have is, can you explain why any forms of exertion would cause the body to want to shut down? So, and either one of you, if you feel like.
Yeah, I mean, I think of it as we have a reptilian brain, and then we have this rational brain, okay? So we've got the cortex, which is kind of rational, is developed later in evolution, and then we've got this more primary reptilian brain that was developed first. And we're living with two brains, okay? And they have to work things out together. And so the reptilian brain wants to preserve energy because that's how it survived in nature. So whenever we exert, the reptilian brain wants to shut down and rest. So I think all sorts of driving forces are getting us to preserve energy and to shut down. There's also an autonomic nervous system that when it's out of whack too, it gets overloaded, or the vagus nerve that's involved in balancing fight and flight and resting states. When that gets out of balance, it also can kind of shut down. So I think it's a great question. It's huge. It's way beyond the scope of. We could probably talk about this for 2 hours, but there's definitely lots of ways of thinking about it.
This next question, which I know is going to be something that you're really interested in, Dr. Bullock, is we have a viewer that said, my 19-year-old daughter has said she is not sure she wants to get better, and to date she has not engaged in any therapies willingly. However, when she tried a virtual reality game, I noticed her movements were more fluid and spontaneous. I have mentioned this to our doctor in Melbourne, Australia, but they're not aware of VR being used in therapy. Are you using it in any therapy? And if so, what sort of results are you getting?
That's a good question. So I'm exploring it in a pilot. So it's exploratory. We don't know anything yet about its use for FND. There's no evidence yet. We're that's why I'm doing the pilot, to be able to get the evidence. So so it makes total sense why your providers would say they're not aware of that. I would say that VR often is a distraction. So often distraction is a type of strategy that can help symptoms sometimes. There is a good evidence base for virtual reality being used for comorbid psychiatric disorders, which are co-occurring often. People with FND often have anxiety, like the rest of the population. 40 to 60% of us have had psychiatric illness at one time or other. And people with FND often have anxiety or mood disorders, where there is a good evidence base for using virtual reality, especially for anxiety disorders. And so for PTSD, it's used for, there's good evidence base for pain control. So it can be used to treat co-occurring disorders.
Thank you. Anything else anyone would like to add to that? No. The next question that we have is from an anonymous viewer. She says, Dr. Stone has conducted trials that show that there are more people who don't develop FND from a psychological event than do. What are your thoughts on this?
So I would say there are studies on resilience, and even after tragic traumas, not everybody would develop PTSD, which is more known to happen after trauma. Most of the people don't develop PTSD. Most of the people also don't develop FND or psychogenic seizures. Every single person is different from the other person. We have vulnerabilities. The type of one person would be susceptible to one type of trauma, and another person could be susceptible to another type of trauma. So we still don't have any way to predict that, like, if all the people would be exposed to a specific type of trauma would develop this type of symptom or not. And that is completely true, that not all the people that are exposed to trauma would develop either PTSD or FND. However, from the other side, when we look at people who have FND or like PTSD, chances of finding childhood trauma or physical trauma or some type of bodily injury is more than, for example, comparing them to patients with epileptic seizures. So it's a two-way to look at it. You look from the trauma to the symptoms and symptoms back to the history. And from symptoms back to the history, there are studies that show that there is some type of trauma, and it's not a causal relationship. These are correlation relationships that you see it more, and it doesn't mean that everybody should have a trauma and work on that trauma in psychotherapy, for example, but we see more correlations.
Yeah, I want to reiterate, this is a multifactorial disease or disorder, and so there's not one cause and effect, and everybody's going to look different, and you've got to customize the treatment, and it's not a cookie cutter. Not everyone looks the same. So
another question, I think probably our last one, since we've used up all of our time, is it possible that a trauma is there but it is not fully? I'm not sure.
it's not what?
I think what she's saying is there a possibility that, and we do have several members that will say, I experienced trauma as a child or and even as an adult, but I feel like I've dealt with it, and it had been dealt with way before I became symptomatic. So is there a possibility that even though that trauma is there, that it's not necessarily correlating with the symptoms?
Yes, I think, again, this is a multifactorial disorder, and so trauma might be a vulnerability, but it's not the key to everything, and you might have addressed that and then need to work on other lifestyle things. I think it's just like migraine treatment. You've got to find the variables that are important for you uniquely, and get the skills around the things that work for you. So everybody's going to be different.
I agree. Every person could be different. I really wish we had a uniform answer for all of our patients. Would have made it much easier for everybody. In terms of trauma, I would say trauma is very, very complicated. And as we say, the word trauma means like a huge injury. And while we are talking about limbic system, the reptilian brain, and memory, there could be different ways that we protect ourselves against those consequences of trauma. That is one thing that in one person we may need to work on trauma still, although we think that we had processed it. But in another person, there might be a trauma, could be a vulnerability point to start the symptoms, but we need more work on the coping skills, or we need more work on getting the person to a process that they can be more engaged in the society, or, for example, being in a group of people that they can try their newly learned skills. So there's not that there's one answer or the other. It needs to be tailored for the person who is receiving the treatment. But it doesn't mean that if somebody worked on a trauma, processed it, it's gone forever. And on the other side, it doesn't mean if a patient has FND that patient needs to work on that trauma for the rest of life. So it's kind of a balance to tailor the treatment for the person that we have with us. And there's not a right or wrong answer there.
Yeah, I couldn't agree more with Dr. Bajestan.
Thank you both. One just final, because another question came in, I hate to not answer, and I'll kind of just paraphrase some of it, is if you do have a family member that can't, or yourself, that you can't handle noises, you can't handle bright light, they're struggling to, even in crowds, manage a lot of people and things like that. How do you desensitize when there are so many things at once that need to be addressed? Is it best to tackle all of them at once a little bit, or is it best to maybe, put the sunglasses on and, avoid the light, but maybe go with sound? Or what's the best approach usually for someone that's trying to?
Well, I think having an experienced therapist can help you. That's why they can kind of coach you and they have the experience. I usually will gauge based on how overwhelming a trigger is, and you need to find that kind of sweet spot where it's not too overwhelming, but it's a little bit challenging. So you need to find the just noticeable difference. So maybe if you can't take a room full of people, maybe, trying with 2 people, then adding 3 people. But that's why I think the potential for virtual reality is great too, because we can practice it, in a non at home, in your own private area, and you can kind of gauge triggers and desensitize. But again, I think the help of an experienced therapist for that is really, really helpful.
Right. So basically the VR kind of helps a controlled environment where you can add in some of these other sensory symptoms possibly.
Yeah, customize it and add. Mm-hmm.
Great. We're going to have you back because there's I can't hear. We're missing. I don't know. That's not muted, so I don't know why we're not hearing you. Sorry, Dr. Bajestan.
Go for it.
I know she does a lot of things on hypnotherapy, and we didn't even get to touch on that. And so I think we're going to have you guys back sometime. So I hope that you guys will agree to join us. And we appreciate all the viewers that have tuned in. And I just want to also mention that we're really excited to start our first FND Neuroscience Supportive Care Program that is going to be at Stanford. And you guys have been very helpful and instrumental in bringing that forward with us. And so we're really excited about that. So we just want to make sure that any of those members who are around in the California area, or if you want to travel, by all means, they will be available to whoever would like to join. They're free of charge, and there will be a schedule on the FND Hope website, as well as Stanford will advertise those as well. Dr. Bullock, you're going to be doing an event coming up too. Can you briefly just tell us that is going to be available on webinar? Yeah, so it's May 25th. At 7 p.m. I think they're going to have a webcast at Stanford Health Library website, and but then it'll be archived so you can watch it later. But I just want to reiterate, with FND Hope, you guys made that support group happen at the hospital. We don't have the bandwidth to kind of be fighting the stigma and the organizational hurdles, and it was really FND Hope that got that group, that support group, to start. So I just want to say how important this organization is. Thank you. We really appreciate that. And I'm going to pass that on. Lauren actually from our marketing team did that, and so we really appreciate the work that she has put forward, because she's done a lot. And I think that those are some of the things that members don't realize that are going on behind the scenes, that the hours that it takes to put things like that together. And we're really hoping that with this model that we can use it as an example for other healthcare facilities to then implement it as well. So it's really historical in a lot of senses and how we're moving everything forward. So we'd like to thank you both for joining us, and thank you, Dr. Bajestan, and we will hopefully catch you on another webinar. So thank you.
Thank you to all of you. Thank you so much.